This program is confidential. Duplication of this program without permission of VHA-TV is prohibited, except for use by participating healthcare organizations.
This program is supported by an educational grant from Amgen and Wyeth Pharmaceuticals. Rheumatoid arthritis is a devastating disease of unknown etiology. It often progresses from joint inflammation and discomfort to full-blown joint destruction or deformation, which causes patient disability. Yet treatment has changed dramatically in the past decade. I'm Vicki Hudson, and today we're going to look at treatment options for rheumatoid arthritis and examine in particular those options that have emerged in the last few years. Joining us for this topic are two distinguished panelists. Dr. Art Weaver, Clinical Professor of Medicine in the Department of Medicine, Division of Rheumatology at the University of Nebraska Medical Center in Omaha. And Dr. Stan Cohen, Clinical Professor in the Department of Internal Medicine at UT Southwestern Medical School in Dallas. Welcome to both of you. Good to have you with us.
Thank you. It's nice to be here.
Thank you. Well, before we move on to the beginning of the presentation, please keep in mind that this program is interactive. At the end, we'll open the phone lines to take your calls. Also, keep in mind that our handout won't always follow the presentation closely, and that's because our presentation has changed since handout distribution. Now, to help set the stage for the discussion, we conducted interviews with clinicians in the field who discussed the various systemic and physiological mechanisms of rheumatoid arthritis and briefly reviewed the history of clinical treatment. Let's take a look.
Rheumatoid arthritis is an inflammatory arthritis. The body responds as if it was fighting an infection in the different joints of the body. It looks for all the world as you would expect if there was an infection in the joints. The cells come out of the bloodstream, go into the joint, and start breaking down the targets that they find within the joint. They use the serum proteins that are part of the inflammatory cascade, proteases, cytokines, and those sort of mediators to help them break down the joint in an attempt to fight off what looks like an infection.
Waking up every morning to brush our teeth, comb our hair, just grab a doorknob or write a sentence with a pen proved very difficult for these patients due to their swelling and stiffness and redness and pain that they have in their joints.
In addition to having swollen joints, the other thing that they noticed right away is profound fatigue. These were some of the most tired, fatigued people you'd ever want to meet, and that's one of the first things that we look for in a response to treatment before the joint stops swelling is, do they feel that their energy level comes back to normal? They don't feel well internally, it's not just their joints. Rheumatoid arthritis can involve other organs of the body too, which is totally different from the osteoarthritis.
We get a good history, we get a good physical exam, and what we're looking for is swelling in their joints, particularly in their hand joints, and that's to be on both sides. We look for morning stiffness greater than an hour is what we look for. And then also there's something called rheumatoid nodules or extra-articular manifestations, which usually comes out in points of like pressure points, elbows, hands.
The treatment of rheumatoid arthritis is certainly multifactorial. Often, even by the time the patients will come to me, they will have tried a non-steroidal anti-inflammatory agent. They can help with pain. They have some anti-inflammatory properties, so they are useful. Many patients will receive therapy with corticosteroids, most typically prednisone and usually orally, usually in lower doses, meaning 7.5 milligrams or less, and usually as a bridge, meaning that we don't want to use prednisone and then have them come back in 5 years and check up on them. We want to use it as a means to get a rapid diminution, a rapid decrease in their inflammation. The next level up, and one that we go to very quickly in patients with rheumatoid arthritis, the so-called DMARDs, disease-modifying antirheumatic drugs. These include a number of agents: methotrexate, sulfasalazine, leflunomide, cyclosporin, gold shots, several others. And then the newer agents, biologic agents, which I think in common practice we'll use early on in people with very severe disease. Still, mostly people get tried with methotrexate or one of the other DMARDs first as we're sorting out their disease activity and as we're trying to get a handle on how severe the disease will be. But in someone with risk factors for a poor outcome and someone with persistent disease activity, we'll use these agents earlier on, and they are probably our strongest available agents that we have available to us right now.
Dr. Weaver, how widespread is this disease?
Well, Vicki, the prevalence of arthritis, there are about 70 million adults in the United States with arthritis or chronic joint symptoms. About 2 million of those people have rheumatoid arthritis. And the characteristics of rheumatoid arthritis, the peak age of onset in the prime years of life, 40 to 60 years of age. It's 2 to 3 times more common in women. It's a chronic, progressive, systemic inflammatory disease of unknown etiology, as you pointed out, characterized by progressive destruction of the synovial joints with loss of cartilage and bone. The ligaments and tendons become damaged. There's a significant loss of physical function and quality of life, and life expectancy is reduced 3 to 18 years.
That's significant. Well, what happens to the patient's quality of life?
Well, the quality of life is significantly impacted. Pain associated with functional disability is significant. Over 80% of these patients have significant fatigue, and up to 40% of the patients suffer depression that significantly impacts their personal and family life. There's a loss of productivity that's well known, average of 30 days of work lost per year, earnings loss of about 50%. We know what the factors are associated with a poor prognosis of this disease: the duration of disease, the high rheumatoid factor titer, sustained elevation of the acute phase reactants, sedimentation rate, the CRP, the number of swollen joints, the presence of rheumatoid nodules or other extra-articular manifestations such as lung involvement, joint erosions on X-ray, delay in therapy, socioeconomic characteristics, low income, low educational levels, also associated with poor prognosis, poor functional status as measured by health assessment questionnaires, which is an easy tool, and genetics. We know that there are genetics involved in this disease as well.
Well, what about the risk of developing other conditions?
Well, the risk of comorbidity in rheumatoid arthritis is significant, and I think we have a chart here that looks at the comorbidities associated with rheumatoid arthritis. On the left-hand side, chronic pulmonary disease occurs over 2 times more commonly in the rheumatoid patient than in the general population. Peptic ulcer disease, 2 times more common, in part related to the medications that we use. And dementia, congestive heart failure, myocardial infarction, cardiovascular disease, all of these cardiac related, 3 to 4 times more common in the rheumatoid population than generally. We know from the Women's Health Study, for instance, that myocardial infarction in rheumatoid arthritis 3 times more commonly in women than in the general population.
Well, what about cardiovascular disease in particular?
Well, cardiovascular disease has achieved significant prominence, and the risk of cardiovascular-related deaths in patients with rheumatoid arthritis, again, is depicted on a slide that we have here. And if you look at the risk of death in rheumatoid arthritis patients, if one has large joint swelling, it's about 1.8 times. Vasculitis, which is a critically important part of rheumatoid arthritis, but fortunately occurs rarely, 2.5 times. If they have lung disease, 3.6 times. Rheumatoid nodules and other destructive changes on X-ray. These are all related to cardiovascular death and are major risk factors.
It's a very important feature. You know, for years we've known that diabetics have a high risk of cardiovascular mortality. And we just only really in the last decade realized that rheumatoid arthritis have the same risk due to inflammation and other factors such as cholesterol and hypertension. And actually studies have shown whereas the death rate from cardiovascular mortality and diabetes has lowered, in rheumatoid arthritis it has not. And it's partly because rheumatologists and physicians involved in the care of RA patients have not recognized and have not been aggressive in treating the various comorbidities that led to cardiovascular mortality. So it's really a major effort that we're trying to make as rheumatologists to educate our colleagues and the patients with rheumatoid arthritis.
Critically important point that Stan points out. We just need to be more aware of the cardiovascular risk in rheumatoid arthritis.
Absolutely. Could you describe how rheumatoid arthritis progresses?
Well, rheumatoid arthritis progresses, and that's probably best depicted with some pictures of hands. These are 3 different patients in various stages of the disease. On the left-hand side, we have very early disease with swelling across the MCP and PIP joints, and this patient obviously has a significant amount of pain and stiffness. The middle picture shows some early deformities with hyperextension of the thumb, swan neck deformities of the fingers, and more significant synovitis across the MCP joints. The last photograph, certainly something that we'd like to avoid and can avoid with appropriate therapy today. Subluxation of the MCPs with ulnar deviation, tremendous amount of synovitis, and you can see the destructive changes in the fingers and thumb.
Well, how early do X-ray changes take place?
Well, X-ray changes occur very early, and again, we have a slide here that basically shows the X-ray progression, and this is the same patient over a period of approximately 5 years. The one labeled A basically shows very little change. The middle X-ray shows some damage and cystic change on the aspect of the inside of that joint on the left-hand side, with increasing sclerosis and slight narrowing of the joint space. And then on the right-hand side, the typical punched-out cystic change that we see with this disease, with joint space narrowing and associated with significant amounts of disability.
What about radiographic abnormalities?
Well, the radiographic abnormalities occur very, very early, and we know that 93% of our patients within the first 2 years will have radiographic abnormalities. The rate of progression is significantly more rapid in the first and second year than it is in subsequent years, and recent studies have shown us that MRIs will show changes in 42% of our patients within 4 months. So this has caused us to become much more aggressive in our therapy.
I can see why. What about the disability in this disease? Is it related to the inflammation?
Well, yes, it is early on. And as you can see in the next slide here, disability and inflammation, disability depicted by the yellow and the inflammation by the green, and they tend to correlate very well for approximately 2 to 3 years. And then there is a disconnect. The yellow tends to rise, the disability tends to rise with time, whereas the inflammation waxes and wanes over a period of years. The important message here is that we've learned that radiographic progression depicted in the red tends to parallel disability. And of course, this is important because disability is associated with cost in this disease.
And that the important thing that I think this also points out is that we want to be very aggressive very early on in the disease. As Art's mentioned, that disability tends to parallel structural damage. And we know now that a delay in therapy of disease-modifying drugs as short as 3 months, 12 weeks, leads to a tremendous increase in radiographic damage that may occur in the next 2 years, resulting in disability down the road. So we want to get patients in early and be very aggressive, and Art will be talking about that.
It's amazing that so much can happen so quickly. What does it cost us in terms of medical expenses, and again, in terms of lost productivity and the personal toll of the disease?
Well, the costs of this disease are significant, and there are direct, indirect, and intangible costs. The direct costs about $5.5 billion per year, including hospitalization, drugs, physician visits, laboratory testing, the costs of allied health personnel, and so on. The indirect costs double that, $10 billion per year, primarily from lost income, lost taxes, and more importantly, the intangible costs we can't measure. The reduced quality of life, the premature mortality that we discussed previously, and so on.
You've got another graph to demonstrate what you're talking about as well.
We do have a graph that shows this and the related costs with increasing disability. And as you can see on the left-hand side, the disability index and this can be measured in a variety of ways. The cost $10,000 per year when there's very little disability, and that's primarily medications. But as you increase the disability, you can see that the cost rises significantly over a period of time.
Now, when should the primary care physician be kind of suspicious of rheumatoid arthritis?
Well, I think suspicion is the key here, and early rheumatology referral to a rheumatologist, I think, is extremely important and advised in the event of any suspicion of this disease. And this would be supported by one of three factors. 3 or more swollen joints, particularly involving the small joints of the hands and feet, the MTPs and the MCPs, a positive squeeze test across the hands or the feet with the patient complaining of discomfort in this regard, and morning stiffness of 30 or more minutes. The morning stiffness in this disease is significant. The ACR, or the American College of Rheumatology criteria that we've identified in diagnosing rheumatoid arthritis, really are not appropriate for early diagnosis. I think suspicion is the key here.
All right. Explain to us how treatment has changed over the years and if it's improved.
Well, I think, and certainly Dr. Cohen is going to discuss the recent advances in some detail, but initially, way back in the 30s, we had gold therapy, and of course this progressed through a multitude of disease-modifying anti-rheumatic drugs, or DMARDs, to methotrexate, which has become the gold standard. And we've learned that we use aggressive doses of these drugs. We oftentimes will use them in combinations, and certainly now with the advent of the biologics, there's been an explosion in the field of therapy here.
Well, the DMARDs that you're talking about, like methotrexate, have proven to be an important treatment option. Explain to us how to best use that methotrexate in treatment.
Well, there's no question that they are an important treatment option, and they're the first treatment option that all of us use. But we're using methotrexate, which, as I said, has been the gold standard for the past 10 years or so, different than we were a decade ago. We start with 10 or 15 milligrams of methotrexate, rapidly increase that dosage to 10 to 25 milligrams, always use it in combination with folic acid, and sometimes we'll switch to parenteral therapy because the oral absorption of methotrexate after 15 milligrams is somewhat unpredictable.
Well, how long do you keep the patient on methotrexate before maybe switching to other therapies?
Well, I think that's an important question, and there was an interesting study presented in Europe this last summer, if you look at this slide. And what is the maximal time that we should keep people on methotrexate? This slide shows methotrexate or leflutamide, which is another disease-modifying drug that was developed in the mid-90s and a very effective, comparable to methotrexate. And you can see at baseline, the two groups started out with similar amounts of disease. And by 2 months and 4 months, they measured their criteria. They both significantly improved with both of these drugs. But you'll see at 2 and 4 months that their response was identical. So what we really learned from this study is that we can tell with aggressive therapy at the end of 2 or 3 months that we need to move on if the patient is not completely treated, or if we can continue on that therapy. So 2 to 3 months, we need to make a change if that patient doesn't have complete control of their symptoms and signs, and even more importantly, as Dr. Cohen will point out, radiographic progression.
And generally what we see in practice, in daily practice in the clinic, is about a third of patients with methotrexate or leflutamide treatment have a tremendous response. About another third have a good response, and third don't respond very well. So the majority of our patients presently do end up on combination therapy. So we're very aggressive, and as Art said, 3 months, don't see significant benefit by then, it's time to move on and generally add therapies.
I'm glad you mentioned combination therapies. Tell us more about those.
Well, combination therapy is commonly used, and the most common combination in the United States is hydroxychloroquine and methotrexate. But the one that probably has the most press and has proven to be the best is what we call triple therapy, which is a combination of methotrexate, hydroxychloroquine, and sulfasalazine. And as you can see by this chart, what these ACR 20, 50, and 70 scores, they're American College of Rheumatology 20% improvement, 50% improvement, and 70% improvement. And as you can see, the triple combination, 78, 55, and 26, is better than double therapy, and double therapy has proven to be better than single therapy with these drugs.
How long do you recommend that patients stay on DMARDs?
Well, I think a very good question, Vicki, and I think that if they're doing beautifully, and as Stan said, 30% of these patients do very well, and if they have complete control of their symptoms and signs, and there's no sign of radiographic progression, we may keep them on methotrexate or a combination of DMARDs indefinitely. However, when we look at DMARD retention rates, and this next slide shows that, we see that high dosage of methotrexate is better than low doses of methotrexate, and certainly better than sulfasalazine or hydroxychloroquine. But there's a deterioration over time of the usage of methotrexate even in high dosage, and that is the difference that we've learned about between the DMARDs and the biologic agents. The biologic agents tend to have a holding power that's relatively stable over time, and we tend to deteriorate with the DMARDs on a yearly basis.
Now, summarize, if you could, for us what we've learned over the years about the efficacy of traditional DMARDs.
Well, I think there are significant limitations of motion, and as I said, methotrexate has been our gold standard. But after 5 years, only 60% will remain on methotrexate. Erosions will occur in 30% of the people in the first year, 70% after 2 years on methotrexate, remission possible in about 2%. This is not a term that we used a lot. Dr. Cohen's going to talk about significantly increased remission rates later on. And 50% of the people will have some upper extremity disability at the end of 5 years on traditional DMARDs.
Well, that brings up the question then, what's the optimal time for treating rheumatoid arthritis?
Well, I think there's a optimal window of opportunity, and the next slide basically shows this, and early established and end-stage disease. And we can help all of these patients. It's not that we shouldn't treat end-stage disease, because we found with these newer agents that they're very effective there and in established disease. Where we would really like to make an impact is in early disease. And what is early? Early 5 years ago was 5 years, and then it changed to 3 years and 2 years, and most rheumatologists now feel that that optimal time to treat that patient, where we can actually stop the progress of the disease, is probably 6 months plus or minus. As the slide points out, severe functional decline, radiographic damage, disability, premature death, all of these things can be prevented.
If you can catch it quick enough. Well, do we know that combinations now are better than monotherapy?
Well, we do know that combinations are better, and the classic trial that showed this was a European trial called, nicknamed the COBRA trial. And on this slide, you see two groups of demographically comparable patients. One treated with sulfasalazine alone, which was the drug of choice in Europe at that time in the mid-90s, and another group treated with sulfasalazine plus prednisone burst plus 7.5 milligrams of methotrexate. After approximately 6 months, the group on methotrexate and prednisone, those were stopped, and the groups were simply on sulfasalazine, both of them. And I think many of us, when we saw this paper, thought that these two lines would eventually come together. But the next slide, which was a landmark paper presented 2 years ago in Arthritis and Rheumatism, which is our national journal, basically looked at these same patients 5 years later. And remember, they're on identical therapy at this point in time from 6 months on. And the patients that had early aggressive therapy up front in those first 6 months had significantly less radiographic damage than did the group that was just treated with sulfasalazine.
Those are some pretty remarkable findings. Explain for us, if you could, the emergence of a new class of DMARDs that's come out in the last, well, just a couple of years, and how this class compares with the traditional DMARDs that we've just been talking about.
Well, I don't want to steal Dr. Cohen's thunder, because this is what he's going to talk about, but the efficacy of DMARDs versus TNF antagonists was looked at again in a paper presented at the European League Against Rheumatism. And we can see the efficacy in this slide of traditional DMARDs, aggressively dosed methotrexate, compared to anti-TNF drugs, and by the yellow bars, and you can see the improvement in the disease activity scores, that's DAS on the left-hand vertical axis, significantly better at 3 months, at 6 months, and at 12 months.
Now, does the use of these biologics have any effect on the cardiovascular comorbidity we were talking about?
Well, I'm glad again you emphasize the comorbidity of the cardiovascular disease because, again, another paper presented this last summer shows the impact of these agents on the cardiovascular events. And those treated on the right-hand side with traditional DMARDs and those treated on the left-hand side with anti-TNF therapy, the number of cardiovascular events basically cut in half. So yes, with these newer therapies, we anticipate that we'll be able to cut down the cardiovascular impact of this disease.
Okay, so in short, what do we need to remember when combating rheumatoid arthritis?
Well, I think the key points. Early referral, crucial in starting effective intensive therapy with DMARDs and/or biologics. Radiographic damage leading to functional disability occurs very early in the disease. The early use of DMARDs is efficacious, it's generally well tolerated. Delaying DMARD therapy reduces its impact. Combination therapy with DMARDs is more effective than single agent therapy. Early DMARD therapy can slow disease progression and reduce mortality and risk. The major lesson, Vicki, early aggressive combination therapy works. What we do early impacts the disease in later years.
Truly great information, Dr. Weaver. Thank you so much.
Thank you.
All right, Dr. Cohen, explain how the newest therapies work in targeting specific areas of the disease process, and what's the basis for their functionality?
Well, it's a wonderful time to be a rheumatologist and a much better time for the patient. In the last 20 years or so, through basic science work, translational medicine, we've been able to understand better the pathogenesis of rheumatoid arthritis. And so we have a cartoon here depiction of what we believe is going on in the synovium of patients with rheumatoid arthritis. And what we've been able to do is develop targeted therapies. In the past, ART did a wonderful job of going through disease-modifying therapies, talking about gold and methotrexate. And these are therapies that we stole from other specialties. We really didn't understand how they worked in rheumatoid arthritis. But you can see here there are various cells which are very important in perpetuating the inflammation of rheumatoid arthritis. Activated T cells, B cells that make autoantibody and present antigen, macrophages that make cytokines such as TNF and IL-1 beta, and then there are cells such as chondrocytes and osteoclasts that lead to those little rat bites, those erosions in the bone. So we have a number of cells that are involved in the chronic inflammation of rheumatoid arthritis that we can use as targeted. So we've left the empirical therapy age and now are in the targeted therapy. Cytokines have been the chief target over the last 5 years with new therapies that block cytokines. Shown here is sort of the halls of justice weight system with the pro-inflammatory cytokines and the anti-inflammatory cytokines. And you can see there's many more pro-inflammatory cytokines than anti-inflammatory cytokines. The most important pro-inflammatory cytokines and the major targets to date have been interleukin-1 and tumor necrosis factor. But there are others. IL-6 inhibitors are in development, IL-18, IL-12. It's also very interesting that there are natural proteins in the body that are anti-inflammatory. I want to focus on interleukin-1 receptor antagonist, which is basically a drug that we have now called anakinra. This is a natural protein that through recombinant DNA technology we were able to develop as a therapy for rheumatoid arthritis. So we have these targets, these cytokine targets that we've now developed therapies against.
Tell us about the biologic treatments that have emerged in the last few years.
In the last 5 years, there have been several new therapies that have been available to us as rheumatologists. There are 3 TNF inhibitors. Etanercept is a TNF inhibitor that is a fusion protein. It's basically the TNF receptor, which is, again, found naturally in the body. And it's given parentally. All of these therapies are either given subcutaneously or intravenously, which is somewhat of a drawback. We don't yet have small molecules that can inhibit TNF. But etanercept is given subcutaneously 2 shots once a week or 1 shot every 3 to 4 days, and again has been found to be quite effective. Infliximab is a monoclonal antibody to TNF, which is a chimeric protein, which means it's partially mouse and partially human. And it's given intravenously. You get 3 treatments for the first 6 weeks, and then every 4 to 8 weeks thereafter treatments are given. Infliximab must be given with methotrexate or other DMARDs because the body can develop an anti-idiotypic response to infliximab, and methotrexate downregulates that. The most recent TNF inhibitor is adalimumab, which is a humanized or totally human monoclonal antibody to TNF. It has a half-life of 10 to 20 days and therefore can be given as a subcutaneous injection every 14 days. and yet we'll show in some data to follow that these generally are all given now in combination with DMARD therapy such as methotrexate. There's one other biologic which is presently available on the market which blocks interleukin-1. And this is anakinra, the interleukin-1 receptor antagonist. And interleukin-1 receptor antagonist binds to the receptor site on cells and blocks the signaling of the cells. As shown here, you can see that IL-1, interleukin-1, has to bind to the type 1 IL-1 receptor and also juxtapose the accessory protein. If anakinra is used as treatment, which is a daily sub-Q administration, this anakinra, IL-1RA, will block this receptor in a competitive antagonist fashion and prevent cell signaling and prevent the activities that can occur that perpetuate inflammation.
All right. Well, can you show us results of research concerning the efficacy of these therapies?
Certainly. There have been a number of studies. Obviously, pivotal studies had to be done before regulatory approval of these new therapies could occur in both the United States and Europe. But I'd like to focus on a very important trial, that what we call the TEMPO trial, which was a trial in over 600 patients. This trial was performed in Europe. Very important trial because it was the first trial that looked at combination therapy with methotrexate plus a biologic, and in this particular study, etanercept, compared to etanercept alone and methotrexate alone with the standard doses that we use. And again, I just want to orient you here. Dr. Weaver's already spoken about the ACR response, 20, 50, and 70% response. And again, this is a response criteria that looks at signs and symptoms: swollen tender joints, pain, disability rating. You see that methotrexate and etanercept led to an ACR 20 response of 75 and 76% and an 85% response with combination therapy. But I really want to point out here, when you look at the ACR 50 and ACR 70% response, with combination therapy, the ACR 50 was 69% compared to 48 and 43%. With the ACR 70, which is a response we never believed that we could achieve in patients over 52 weeks, 43% of patients achieved a 70% improvement in their signs and symptoms compared to only 19 and 24% of patients on monotherapy. In addition to the improvement in signs and symptoms in this study, there was significant improvement in functional disability. Dr. Weaver's mentioned about the health assessment questionnaire, a very simple form patients can fill out in your office, takes about a minute to fill out. And what you see here is on the x-axis, the 52 weeks, the y-axis is the percent improvement. The combination therapy is shown in yellow, the monotherapy is methotrexate and etanercept in orange and blue. All three therapies were very effective in improving physical function and reducing disability, but again, combination therapy was superior. Another outcome looked at in this study was clinical remission. As Dr. Weaver mentioned, remission was not in our vocabulary until recently. We now strive, and our goal now is remission of the patient with rheumatoid arthritis. In this study, 14 and 18% of patients at week 52 achieve remission with monotherapy by criteria that have been validated to indicate remission. 37% of patients on methotrexate and etanercept achieve remission. Double the amount of patients achieve remission. And the important thing here, not only in this trial, there have been two other trials now which have confirmed that the combination of a biologic plus methotrexate doubles your chance of remitting from this disease. And that's why in daily practice we move very quickly in those methotrexate patients who have a partial response or minimal response to add a biologic. The other very important piece of data in this study was the X-ray outcomes. Dr. Weaver made a strong point how X-ray correlates with disability over 15 to 20 years of disease. Here in this particular study, we looked at what's called the SHARP score, which is a methodology that looks at the erosions in the joints, the loss of cartilage is measured by joint space narrowing, and comes up with a number. And what you can see in the yellow is the methotrexate patients had some progression of their disease, 2.8 SHARP units over 52 weeks. Etanercept 0.52, almost zero. But the combination therapy actually had a negative number, suggesting that we might actually be seeing some healing that could occur in these patients. So what we've learned is that in patients receiving TNF inhibitors, we essentially can block X-ray structural damage in those patients. And that's what we did not have with conventional disease-modifying therapy.
Those are some amazing results. Did you want to jump in?
Yeah, I think, Vicki, one of the very, very important aspects of the TEMPO trial, the graph that Stan showed regarding the response with methotrexate and etanercept were very, very similar. That's controlling symptoms and signs, as Stan pointed out. But then when you go to the radiographic damage, there's a total disconnect. Etanercept looked markedly better than the DMARD therapy. And this is where the disconnect. Not only do we need to control symptoms and signs, we need to stop radiographic progression.
That makes so much sense. I'm glad you said that. What What other targeted therapies might be helpful? What's on the horizon? What's coming up?
Well, Vicki, as we mentioned when we started this portion on biologics, there are a number of potential targets. And certainly for the last 20 years, we've thought that the T cell would be a prime target to try to downregulate. Early clinical trials trying to inhibit T cell function weren't particularly successful. But we now have some information that that indeed may be an effective way to treat rheumatoid arthritis. Shown here is again, a depiction of what happens when a T cell is activated. In the orange, looks like the sun there, the activated autoimmune effector T cell. When a T cell is activated, it has many downstream activities. It stimulates macrophages to make cytokines such as IL-1, TNF-alpha, and IL-6. It activates dendritic cells, which are very important antigen-presenting cells, but also can produce cytokines, and then also activates B cells, which make autoantibodies such as rheumatoid factor and other cytokines. So T cell activation is very, very important. Now, for a T cell to become activated, there has to be presentation of antigens as well as co-stimulatory molecules. So shown here again in the blue is an antigen-presenting cell, and in the green is the major histocompatibility complex, which is where antigen sits, and presented to a T cell receptor on a T cell. Now, the T cell cannot become activated unless there is a second signal, a co-stimulatory signal. And shown here is one of the co-stimulatory molecules, CD80/86, which is found on the surface of antigen-presenting cells. And again, it ligands with CD28 on the T cell. The fact that both of these signals occur, the T cell becomes activated. Now, there is a new therapy, CTLA-4 Ig, which is in late phase 3 clinical development, which works by blocking co-stimulation, by blocking the co-stimulatory molecules. And as shown here, CTLA-4 will attach, it's a monoclonal antibody given intravenously, generally on an every 4-week basis, will attach to the CD80, CD86 receptor on antigen-presenting cells and prevent that second signal from occurring, prevent the stimulation of the T cell. So the T cell is, even though antigen is presented to the T cell receptor, the T cell is unable to be activated, and it may actually induce T cell tolerance. So again, by blocking T cell activation downstream, the other effects don't occur, cytokine production doesn't occur, and inflammation is lessened.
Okay, so what are we finding to be the contribution of B cells to the disease?
Well, this is actually a very exciting era. When I trained in the 70s, we thought the B cells were very important because B cells are what mature into plasma cells and lead to rheumatoid factor activity. But then for about 20 years, B cells were forgotten about. Now we know that B cells are extremely important in rheumatoid arthritis. It turns out that B cells do make autoantibodies like rheumatoid factor, but B cells are very important for antigen presentation, activation of T cells, as well as activation of macrophages, which leading to cytokine production. So again, a very ripe area for investigation, and trials are ongoing now.
Well, when you're talking about targeting the B cell, what kind of therapy has emerged?
There are several therapies that are being looked at. Rituximab is the one that's farthest along in development. Rituximab is a therapy that's already approved for the treatment of non-Hodgkin's lymphoma, and has been very effective in that disease. Rituximab is a chimeric monoclonal antibody, so again, partially mouse, partially human. It attaches to the CD20 protein on the surface of B cells, and by attaching to this CD20 protein through various mechanisms, it depletes B cells. So the B cells die, become apoptotic. So what you see here is a clinical trial of looking at what happened to B cells, and this is a trial looking at Rituxan alone in yellow, rituximab plus Cytoxan in combination therapy, and rituximab plus methotrexate background. And all of these people received 2 doses of Rituxan at day 1 and day 15, and that was it. There was no further rituximab treatment. And what you can see on the y-axis, that represents the actual CD19 count, and CD19 is a marker of B cells. So what we're looking at is what happens to the B cells. And what you can see is almost within just 2 weeks, there are no B cells measurable. When you measure in the blood, there are no B cells. And for 6 months, you cannot measure B cells with any of these therapies. But from 6 months on, there's repopulation of the B cells that occurs. Now, the correlate of that, that's wonderful and fine and dandy, but how do the patients do? And so basically, the clinical trial results from this trial are shown here. And this is somewhat of a busy slide. I just want to orient you. This was the same trial looking at 48-week response, rituximab therapy versus methotrexate alone. So we have the first column on the far left is methotrexate alone. Second column is rituximab therapy without any background methotrexate. Third column is rituximab plus Cytoxan without background therapy. And the fourth is rituximab plus methotrexate. You see on, again, the far left, the ACR20, ACR50, and ACR70. And I want you to focus on the people just continuing on methotrexate. Only 20% of patients achieved an ACR20 response, only 5% ACR50, and none ACR70. When you take a look at the far right column, rituximab plus methotrexate, 65% of patients achieved an ACR20 response, 35% in ACR50, and 15% in ACR70, very similar to results to what we've seen with other biologics. And this trial has stimulated, trials are now ongoing in over 1,000 patients to try to determine how effective this therapy might be in the short term and what happens when you retreat patients long term.
Let me ask you something. What are the other therapeutic target areas we're talking about?
Well, there are many different many different targets that we can go after. Our goal is to come up with small molecules, pills, that a patient can take that would require a lot less manufacturing cost and so forth. So there are a number of mediators that we know, and we look at cell signaling. They're a very attractive target, kinases. Kinases are enzymes which, after a cell is signaled, they carry that signal down to the nucleus, and DNA is made, RNA replication occurs, and proteins are made. So MAP kinases are very intriguing targets, and one particular MAP kinase is the P38 kinase, MAP kinase. And there have been a number of preclinical trials in animals, and now actually trials in humans that are ongoing. Shown here is a trial in collagen-induced arthritis, which is a very common preclinical model for rheumatoid arthritis, and we're looking at blocking P38 kinase. You can see on the top, again, we have this is day 0 to day 7 post-onset of arthritis, and on the y-axis, we're just measuring the swelling of an animal's paw. And what you can see in the control animal who received no therapy, they get significant swelling of the paw. And if you scroll down the text, you see indomethacin, you see soluble TNF receptor. If you get down to the bottom, you see 30 milligrams per kilogram per day of a P38 inhibitor. And what you see is by giving this animal a P38 kinase inhibitor, no paw swelling occurred. So that has stimulated a great deal of interest in these types of small molecules, and studies are ongoing in humans now to determine if this will be an effective and safe therapy.
Was the animal a mouse?
The animal is a mouse.
All right. Well, recently we conducted interviews in the field, and we heard about cases that demonstrated the effect some of these targeted biologic therapies have had in patient lives. Let's take a look.
The case of this businessman comes to mind. And this is a true story, in fact. I saw him first about a year ago. He was quite incapacitated, hardly able to walk around, not able to enjoy the company of his family, unable to really travel. Just going to the office every day proved very difficult. He had failed traditional agents such as corticosteroids and methotrexate, and then we consider the newer biologicals. And in a period of about 6 months, he was a different man. He was a different person. The pain went away, the stiffness went away, the misery that he was going through sort of disappeared, just about 90%. And he became functional.
When etanercept or Enbrel first came out, that was the first of the real wonder drugs for us, a TNF-alpha inhibitor. We had patients who had been waiting for something new. So most of the early etanercept patients were our worst patients. And I saw a lady who came in, and I was probably the 5th rheumatologist in her life who had been involved with her. And she was on 4 drugs at that time. She was on methotrexate, cyclosporin, Plaquenil, an anti-malarial drug, and prednisone. And she was still doing poorly. And I had been telling her that this drug was coming out. And indeed, she went on to the drug, and I saw her about 3 weeks later, and I'd never seen her out of a wheelchair. And for the first time, this lady walked into my office. And, you know, I was kind of in shock. It was like looking at a completely different person. And that was one of my most severe patients. And I thought, oh my gosh, if this will work for her, you know, can I please put this in the water supply?
These therapies are able to restore, you know, their sense of control over their lives that they lost from rheumatoid.
You have got to agree those were some pretty powerful patient stories. Are those results typical in what you've been seeing in clinical practice?
I think these biologics have really revolutionized the care of our patients. And again, as we said when I first started, it's a lot more fun to be a rheumatologist, a lot more fun to be a patient. We focused on the fatigue that occurs in these patients. One thing these therapies do, in contrast to many of our DMARDs, is they dramatically improve energy and suppress fatigue. And so we have this phenomenon in Texas we call born-again rheumatoids, and they'll come in our office a week or two or a month later and hug us, and just they've gotten their life back, and that's just such a joy.
It was very interesting when we did Stan and I both had the opportunity to do the early trials with all 3 of these anti-TNF drugs. And they were double-blinded trials, which means we didn't know and the patient didn't know what they were receiving, but it became very obvious after 1 or 2 weeks that they were on an active drug. And as Stan said, it's immediate. There's a tremendous increase in energy in these people, and the fatigue, which is a major part of this disease, rapidly disappears.
Boy, I think that one doc was right. Can we put this in the water? That's great stuff. You're right. I want to thank both of you so very much for being with us today. And now it's time to open our phone lines to hear your comments and questions. Our toll-free number is 1-800-842-2032. Give us a call and give us only your first name and the city from which you're calling. And while we're waiting for those calls, let me ask you this, fellas. What are some of the cautionary issues and considerations we face with these therapies?
I'm glad you asked that, because I don't want to put this in the water supply. Okay. I think that this is a very effective therapy, but it has to have its proper place. And as doctors, our task is evaluating benefit and evaluating risk. And when I sit down with a patient who has moderate to significant disease, who I feel is a candidate for progressing to radiographic destruction and disability, I can certainly make a strong case for adding these therapies to methotrexate, or maybe in a few years even initiating these therapies prior to methotrexate. But there are concerns. These do suppress the immune system. There is definitely a higher risk of opportunistic infections. We certainly learned very on that those who had previously been exposed to tuberculosis may have a higher risk of recurrence, so now we screen all our patients for previous involvement with TB. Serious affections can occur, certainly in those with chronic lung disease, diabetics, patients on corticosteroids. We've been concerned about malignancies, not solid cell malignancies, that's not a concern. We've been concerned about lymphoma. School's still out there. We don't think these drugs increase the risk of lymphoma, but more long-term data is going to be necessary. Rare side effects occurring in about less than 1 in 10,000 can include multiple sclerosis type illnesses, bone marrow suppression, lupus-like syndrome that can occur, and with any parenteral therapy, you can have administration reactions. You can have infusion reactions to intravenous therapy. You can have rashes and irritation to the sub-Q injections. So it's extremely important that we make sure the audience understands these are phenomenal breakthroughs in the management of patients with rheumatoid arthritis, but they have their proper place, and they should not be given glibly. Informed consent has to be provided to the patients so they can make educated choices based on your instruction.
Stan is absolutely correct. I think the patient needs to be extremely well informed. These drugs need to be monitored very closely. And that's not to say that the traditional DMARDs are totally safe either. They need to be monitored like methotrexate with liver function studies, appropriate laboratory studies, and so on. So these drugs should be in the hands of someone that deals commonly with these diseases on a regular basis.
Well said. I want to remind you that the phone lines are now open. The telephone number is 1-800-842-2032. And while we're waiting for those calls, let me ask you something else, guys. What are some of the considerations we have yet to resolve regarding these new therapies?
Well, there's still a number of unresolved issues. Again, we've only had these therapies in the marketplace for patients for 5 years. We know that the therapies are effective, but we're still learning is how durable is the response. Are patients going to have a 10-year response, a 3-year response? We need to find out who are the patients who are candidates. We need to find out who are the patients who are candidates for these therapies. How do we select the correct patient? The next decade or two is going to be the decade of proteomics and genomics, where we can actually profile a patient and say, you'll respond to a cytokine inhibitor. You may respond to a T-cell inhibitor, and we'll be able to tailor our therapies. The safety issues I've mentioned, infections, malignancy, some patients develop antibodies to these therapies, which downregulates the efficacy as well as may increase safety concerns. Most importantly, what about cost? These therapies are extremely expensive. We're talking about the range of $15,000 to $30,000 a year. And with higher copays, higher deductibles, I think we're really going to get in a tough situation in this country when we have therapies for patients that can really make a significant difference in their quality of life, but the therapies may not be affordable. So our hope for the future is we'll take what we've learned from science, basic science, come up with small molecules that will be less expensive to allow us to manage these patients. But that's going to be a tremendous struggle for all of us in the next decade or so.
Stan did a beautiful job of explaining with cartoons the complexity of this disease and the inflammatory cytokines. And he also talked about evolving therapies. And with these dramatic new therapies, why do we look for new things all the time? Well, he talked briefly about small molecules. And smaller molecules will be able to be put into an oral form. And anytime you can stamp out pills, it's going to be much less expensive than creating a biologic agent. They are extremely difficult and expensive to produce.
And certainly more convenient in a pill form.
No question.
All right, we've pretty much covered this, but let's hit it one more time. Why not start the biologics immediately?
Well, I think that, first of all, traditional DMARDs will work. As Stan pointed out, about 30 to 35% of the patients will have a dramatic response to aggressive, high-dosage methotrexate, sometimes used in combinations with other DMARDs. And at a cost of $700 to $900 a year, that's significantly less expensive than these new biologic agents. On the other hand, we need to progress rapidly after 3 months or so if that patient has not a complete cessation of symptoms and signs, or if there's any sign of radiographic progression, be it with MRI or ultrasound or traditional X-ray.
All right. Let me remind our audience that we are going to be running out of phone time any minute now, and if you do have a question, now truly is the time. Our toll-free number is 1-800-842-2032. Hey, how do we pick a particular biologic for a patient?
Well, again, that's a discussion that you have with the patient. Some patients would prefer to have an intravenous infusion. Some people are shy about self-injecting themselves. Some of the issues that occur are insurance issues that occur, and that for Medicare up until just recently, they would only pay for infliximab, which is an intravenous infusion, would not pay for outpatient subcutaneous injection. So my particular bias is that all three therapies work in equivalent fashion, and that the toxicity of all three agents is similar. So I sit down and give the patient their option and let the patient help me make that decision.
Really?
Yes.
Well, that's good news for both you and the patient, I guess. Is there a shortage of rheumatologists in the U.S.?
Well, there is a shortage of rheumatologists, and by the year 2010, we'll be about 5,000 short. And there's a significant waiting list to see a rheumatologist. And I think this is, on the other hand, if the primary care physician would pick up the phone and say, I have a patient with inflammatory disease, that is a patient that will work into our schedule very rapidly.
And a number of our colleagues have started early arthritis clinics to try to make sure that those patients who need to be seen early on can get into clinic very quickly.
All right. Well, the last question I have is, should primary care docs use these new biologics?
Well, I don't think so at this point. I think that biologics are very, very complicated, and you know, just my parallels, when I first finished my training, I thought I was a pretty good general internist and could take care of diabetes. There's no way I could take care of diabetes at this point. They're far too complicated, too many upsides and too many downsides.
All right. Any final thoughts as we close out today's program?
I think the major message from my standpoint would be early, aggressive therapy, often in combination, a disconnect between controlling symptoms and signs and radiographic progression, and move on if you don't have complete control of the disease to the more effective agents that we have developed.
Okay. Yes, sir?
I concur wholeheartedly. I know that's really where we are. It's just, like I said, it's a phenomenal time to see the changes that have translated from basic science research to the clinic so quickly. We got wonderful targets to go after. I think that we can now, for 80 to 85% of patients with rheumatoid arthritis, almost assure them a very good quality of life and to prevent disability and deformity.
Totally agree.
Can you see 5 years down the road, and if so, what do you see?
Well, I see continued improvement 5 years down the road. Whether we'll have a cure at that time, Vicki, I'm not sure, but we're closing in on it very rapidly. There's a multitude of these cytokines that Stan has identified that are targets, and we're knocking them off one by one. Stan?
Well, I think the proteomics and genomics is going to revolutionize where we're heading. I think that when we can determine which patients with certain genetic bias are going to respond to certain types of intervention, then I really think we'll be able to tailor that targeted therapy, and I think our outcomes will be enhanced.
Pharmacogenomics are the next major thrust. I would agree.
You know, I really appreciate something. I think Stan, you said in the past remission was not in our vocabulary, and I heard you use the word cure.
Right.
So that means good things are probably going to be on the horizon. It's just a matter of time.
There's no question about it.
So.
Guys, thank you so very much for being here. I'd like to thank Dr. Stan Cohen and Dr. Art Weaver for joining us today, as well as all of you who allowed us to interview you on videotape. Thanks to all who took the time out of your busy schedules to join us for this broadcast. And now please take just a few minutes more and fill out the evaluation forms in front of you. They allow us to plan future programming, and we certainly appreciate your participation. And now for VHA TV, I'm Vicki Hudson, and thanks for watching. This program is supported by an educational grant from Amgen Wyeth Pharmaceutical.